and welcome to to Conversations with the Council, a new video series featuring unique and interesting perspectives from across the wide world of benefits. I'm Lynn Dudley, Senior Vice President, Global Retirement and Compensation Policy for the American Benefits Council, an employee benefits public policy organization that advocates for employers, connecting public policy and private sector solutions to shape employee benefits for an evolving global workforce. Our debut episode takes a closer look at the global workforce, specifically Dr. Lazar's discussion of diabetes through the employee's eyes. I'm joined by my colleagues here at the American Benefits Council, Richard Polak, Senior Advisor, Global Affairs, and our special guest, Dr. David B. Lazar of Lazar Retina. Now, I'd like to turn it over to you, Richard, to introduce Dr. Lazar and get started with our discussion.
Thank you, Lynn. Thanks very much. Thank you, Doctor, for joining us. I'm so excited to have you speak on this very, very important topic. I was blessed to be treated by Dr. Lazar in a retina tear I had, and then discovered all these issues around diabetes globally that affect us all, and that he discovers it through our eyes, or one way through our eyes that really affects us all. And I'm not going to talk anymore. He's a doctor. That's all you need to know. An MD, a real live MD, and he'll tell you what he's discovered and all the research he's done on this important topic, that and with actionable items at the end that we as benefits managers, HR managers, global directors, to be able to help our employees. All right, Dr. Lazar, go ahead whenever you're ready and how you want to put up the presentation.
Great. Well, thank you so much for having me, Richard, and everyone. I'm very happy to be here this morning. So let's force, and again, I'm really happy to be here. So thank you again, Richard, for the kind invitation. Diabetes is a global disease that involves poor ability to metabolize sugar in the blood, and that's really the basis of the disease. It's you eat food, and the sugar that you digest does not get metabolized properly, and as we'll discuss, affects the entire body, including the back of the eyes, called the retina. This is a global disease, and here's a map of the current prevalence of diabetes in the world. And as you can see, the United States, China, and India are the world leaders in diabetic patients. This is a global disease that is only increasing. As you can see here in 2019, the global prevalence of diabetes in the world is around 463 million people, and it's expected to almost double by year 2045 to around 700 million people around the world. Keep in mind, all of my projections in this presentation today will be focusing on working age adults. So when I say 700 million people in year 2045 will have diabetes, that is of working age population. When we tease out what areas globally are going to be most affected by an increase in prevalence of diabetes, we see that the African continent, Middle East and North Africa, as well as Southeast Asia, we're going to see the biggest increase in diabetic patients globally. And when you really get into the nitty-gritty of the data, you see that this is really a disease of high-income and middle-income countries. So in this graph, we have the prevalence of people associated by diabetes by age and income group. In the x-axis here, we have age, and the y-axis, we have percentage of people affected by diabetes. And what we can clearly see is that high-income and middle-income countries are disproportionately affected by diabetes than low-income countries.
You're going to tell us why, or can you tell us why not?
Sure. One of the main reasons is diet. And if we go back a slide here to the regions, all the countries that are starting to adopt westernized culture, that includes food and diet and exercise. And so all these countries here that are adopting westernized countries are more susceptible to diabetes, because in the Western world, we eat a lot and we don't exercise enough. And when you look at Europe specifically in this graph, you can see that they're projected to have a very, very small increase in diabetes, only 15%, over the next 20 to 25 years. And that's because of the way they live their lives, their diet and their exercise. So when we say that this is a disease that disproportionately affects high and middle income countries, that's because those countries are the most westernized, and with that comes diet and lifestyle changes. Getting more into the nitty-gritty, you could see that this, is a urban disease as well. Here we have people living. Here we have people living with diabetes, working age, as it is between urban and rural areas, and clearly this is disproportionately affecting urban areas. And again, that plays into the concept that this is a westernized disease with high diet, low exercise, in a working environment, sitting at a desk, and really you don't see it as much in more rural areas, perhaps, where the diet is different and the exercise is also more vigorous.
When you say diet, you mean heavy fat diet, meats? What do you mean?
Well, that's really a whole nother discussion. That could be a 5-hour discussion in itself. But the reality is that it's quantity. It's the westernized diet. We have a quantity problem. It's not really, obviously there's high fructose corn syrup, and we do like our sugars in our food, but really it's an issue of quantity and size. And the European culture has really a more appropriate portion control, and it's really more portions than type of food.
So when we go to a restaurant and say, wow, that's a healthy portion, that's really anti-intuitive, right?
Yes, that means yes. If you go to like a cheesecake factory and you see the portion size there, that's really should be like 4 or 5 meals. So this is one of the most important slides, I think, in this whole presentation. And what it says is that almost 2/3 or 63% of people with diabetes are of working age. And what I'm about to get into is why that's so important. So again, 2/3 of people with diabetes are of working age, and it is the leading cause of vision loss in patients who are working age. So for example, if you are an employer and your employees between the age of 20 and 74, and they don't show up to work because they say they're having vision difficulties, the overwhelming odds are that their visual difficulties are related to diabetes and how diabetes affects the eyes. So this is a critical take-home slide that diabetes affects everyone in the world. It's a growing problem, and it really is the leading cause of vision loss for working age adults. So it's something that we all have a vested interest in addressing, both from a health perspective on my side and as a employer side. So how does diabetes really affect the eyes? So as I mentioned previously, diabetes is due to an inability for the body to metabolize sugar. So what that means is that when we eat food, the sugar that is supposed to go into our cells cannot do so appropriately, and it actually stays in our blood. And it turns out that sugar in our blood can be toxic to the blood vessels that carry the blood. So think of it like, if you think of the blood vessel like a garden hose, and the blood is the water. When you have a running water over the course of your lifetime, if there's too much sugar in there, it's like it pokes holes into that garden hose and causes the garden hose to become leaky. So that's a long way of saying it damages small blood vessels. Sugar in the blood damages small blood vessels. So everywhere in the body where you have small blood vessels will be affected by diabetes, and one of those areas is the retina. So this is a schematic picture of your retina, and what I tell my patients is that the retina is nothing more than film in a camera. If your eyeball is the camera, the retina is the film. And so diabetes does affect that film. So here's a slide of someone's retina that's affected by diabetes. And as I mentioned, here's a small blood vessel that carries blood to feed the retina. And what we can see here are these outpouchings, these aneurysms here caused by diabetes. As I mentioned, the blood, the sugar that is flowing through these blood vessels causes damage to them over time. And you see these outpouchings. And what these outpouchings cause is leakage into the retina. And this is what that leakage looks like. So here we have a scan that I frequently take in my office called an OCT, or optical coherence tomography. And it allows us to look at the retina at a cellular level. And what's clear is that here is normal retina. Here's how it's supposed to be, nice and dehydrated with no leakage. And here's a diabetic patient with extensive swelling of the retina from those outpouchings from the diabetes. So clearly, if you think of your retina like film or like a circuit board, it's not going to fire appropriately or work appropriately if there's all this leakage. And we have many ways, which I'm going to get into, on how we can treat this leakage, but it's very, very costly for society and very burdensome for the patient because it requires many visits. So the trick is to really, if we're going to talk about how we should really address diabetes, it's to prevent our patients from even getting to this level. So how can we be proactive in preventing our patients from getting to this level of a swollen retina and vision loss? Well, it turns out that very, very strict blood sugar control can prevent this from happening. It's not rocket science, right? I mentioned that high blood sugar causes damage. Well, if we lower the blood sugar, we know that it'll prevent the damage. So this is a very, very famous study here where researchers took two groups of people with diabetes, obviously. The primary prevention group were diabetic patients who had no blood sugar, who had no diabetic eye disease. The second group were diabetics with mild or moderate diabetic eye disease. And the question they posed was, if we take these two groups of patients and we really strictly control their blood sugar, whether that's with medication or from diet and exercise, will that have an impact on the level of disease in their retina? And you can intuitively hope that yes, it would. And it turns out that that is true. So here is the graph that represents the primary cohort, which is the group of people who were diabetic but did not have diabetic eye disease. And what you can see here, when you have their cumulative risk of progression of eye disease over years, that intensive blood sugar control here with the green bar shows that they have a much less likely risk of developing eye disease, 10% risk over years, compared to around a 60% or 55% risk if you don't control their blood sugar appropriately. So this is for people who have not yet developed diabetic eye disease, but are diabetic. The same thing, almost an identical graph is seen for diabetics who have expressed eye disease from diabetes, where if you intensively control their blood sugar intake and digestion, they have a much less likely risk of progression than if they don't, okay? So what this is basically saying is whether you have a diabetic patient who just has diabetes with no eye involvement, or they're a diabetic patient with eye involvement, if you strictly control their blood sugar, they do better and they have less complications of the eye. That's essentially what those two slides are saying.
And how hard is it to control their blood sugar?
That's an excellent question. And really what it depends on is, it depends on a lot of things, but most importantly, it depends on how motivated the patient is. You know, what I tell my patients is that no one is going to care about their health as much as they should. So they need to be proactive participants in their health. So if you have patients that really aren't motivated to staying healthy and they're not motivated to having long-term good blood sugar control, they're going to end up in a bad place, no matter how aggressive I can treat them in the office. A caveat to that is there's the social network, meaning if you have a patient that might not be very interested in controlling their blood sugar for various reasons, if they have a wife or a husband or a son or a daughter that is motivated for them, that is a very important factor in how well they can keep their blood sugar under control, because it really does take a village to stay healthy. So the question is, why should we really care? You know, we should care because it's important for our employees' health. It's important for everyone to stay healthy from a society perspective, but it's also really, really expensive to treat diabetic patients with regard to their eye disease. So here we have a global healthcare expenditure of diabetic disease in working class people with diabetes. And what you can see is from 2016, the diabetic healthcare expenditure globally was around $200 billion. Well, fast forward to 2019, and the global expenditure increased to about $750 billion. That's total healthcare expenditure just for diabetes in working class people. So not only is this a societal issue, but it's really an economic issue for everyone. If you tease out that data a little bit and look at the same point of percentage of total healthcare spending allocation, but you look at it per region, you could see that the North American continent spend about 10% of every healthcare dollar goes towards diabetic disease. In Africa, it's about 12% of every healthcare dollar goes towards diabetic disease. So again, another way of saying this is a huge economic burden globally.
So if I remember, Africa had they have a high percentage, even though you have a low percentage of diabetes, of that percentage, it's a higher amount of their healthcare spend.
Correct. And so that's because they might not be spending their dollars effectively, right? Just because you spend dollars, you can spend it more effectively than other ways. And actually, that's a really nice segue into what I'm about to get into. Excuse me. Which is when discussing the costs of diabetic eye disease, it can be teased out into two different categories: the direct cost and the indirect cost. So when we're going to talk about the direct cost first, and what that means is the direct cost of treating the patient. So that there's a lot of different ways of looking at that. When a diabetic patient comes in and their retina is as swollen as the one that I showed you in the previous slide, I inject medicine into their eye in the office. Richard, you were lucky enough that we didn't have to have that discussion, but I do it all day, every day. And here's a schematic of what it looks like. Here's a patient's eyeball. And in the office, I obviously numb the eye and I inject medicine here that goes into the back part of the eye here and takes the swelling away from the retina. And this is given in diabetics monthly. And there's tremendous cost associated with, number one, having the patient come to the office, missing work, having someone drive them, doing this monthly, and then there's cost with the injection itself. So let's go into that. These injections are just ubiquitous in the healthcare system. Using Medicare data of 2015, about 3 million of these intravitreal eye injections were given in the US alone. And again, a vast majority of those injections are related to diabetes. That's 3 million in 1 year, and that's almost 6 years ago. The drugs that we use to treat diabetic eye disease are in two different categories: steroids and these newer anti-VEGF medications. They are both exceptionally expensive. So here are the four mainstay of these steroids, and here they are. There's Kenalog, which is about $20 just for the medication. That does not include the cost of injecting the medicine. You can use an Iluvien implant, which costs around $9,000, Retisert implant, which costs around $20,000 and has to be done in the operating room. So there's about the implant itself is $20,000, and then just the cost of taking the patient to the operating room to implant it is another $20,000. And then this office implant here, which I use routinely, costs around $1,400 per implant. So that's just the steroid medication. These newer class of medications also vary in cost, from $46 for a drug called Avastin. Lucentis is a little bit of a newer drug, and that's about $1,800 per injection. And the newest kind of gold standard drug that we use is $1,900 per injection. Now take a second and understand that these injections for diabetes are given monthly. So these injections, let's say you have a patient on Eylea and they have diabetes causing swelling in their retina, they will be getting a $1,900 injection monthly, potentially for years. So this is what I'm talking about. The direct cost in the healthcare system of diabetes is really tremendous. So here's a graph of the global diabetic retinopathy market in 2014 to 15 in billions of dollars. So what you can see is that we spent globally in 2014 around $5 billion just on these medications globally. The medications are these purple part of the graph. So that's $5 billion globally we spent just on those medications that I showed you in the previous slides. Fast forward to today, we're about $8 billion globally just on those medications. And then when you go fast forward a little bit further, that number is going to be closer to $10 billion just on those medications globally. Those are the direct costs of treating a patient. Well, the indirect costs are nothing to scoff at either. And indirect costs are really everything else that goes along with treating a diabetic patient, not related to the medicine itself. So I mentioned previously that diabetes affects patients of working age people. Well, it just so happens that we know that when working age people have to miss work to come in to get injections, and they're sick and they can't see, depression is a huge issue. So there's costs associated with depression, injury, and visual rehabilitation. Again, these are considered indirect costs of eye disease from diabetes. And we know that there's a number tag, a price tag associated with that. If a patient has moderate eye disease, that usually costs around $3,000 per year just in indirect costs. If there's severe eye disease, that costs the system around $5,500 in indirect costs. And if the patient is legally blind, if the patient is legally blind, that costs in indirect costs around $7,000 per year. Again, this is totally separate from the direct costs that I had previously talked about of the medication. There's another huge indirect cost, and that is the cost of missing work. Patients miss work for various reasons. They have to come into my office. They have to have family come into their office. They miss work because they can't see. And even if they do show up to work, there's an indirect cost associated with decreased productivity because they can't see well. But one of the biggest indirect costs of diabetes is death. These patients unfortunately die earlier than healthy patients, and the global estimation, this is of last year, I believe, early death associated with diabetes globally was 3.1 million people. So 3.1 million people died earlier than they should have last year because of diabetes. And that obviously has a tremendous rippling effect in the global workforce. So this is the second take-home slide, and I know it's very busy, but I've circled the important part in yellow. This slide takes the both direct and indirect costs and put them together for patients with diabetes and tells us how much it costs per year for these patients. And the answer is $6,320. So to say that again, if you have an employee or if I have a patient, it costs the healthcare system $6,320 more than if that same person did not have diabetic eye disease per year. As you can imagine, if you have 1,000 employees with diabetic eye disease, that means that diabetes costs your company around $6.3 million per year just to treat those patients. What I'm saying is nothing novel. You know, even industry is aware of this huge issue, and there are many companies who are getting into this space to help identify diabetic patients through retinopathy, through identifying their retinopathy. Google, Microsoft, and some smaller companies have gotten into using artificial intelligence and deep learning in a really interesting way. What they've done is created basically algorithms that you can take a patient's photo of their retina, feed it into this artificial intelligence machine, and then it spits out a % risk of going blind. So if you have let's say a patient or an employee, you take a picture of their retina, which can be done routinely. I have a camera in my office that I use all the time. It takes about 2 seconds. You feed it into the computer, and the computer will say, this patient has a 10% chance of going blind over the next 5 years. So with this data, it can help us identify which patients are we really need to be on top of in terms of blood sugar control and medical management. So not only industry is involved, but obviously the medical community is also using these same ways of deep learning and artificial intelligence to look at patient health. And this is one of my favorite papers here in the middle, where it's titled Prediction of Cardiovascular Risk from Retinal Fundus Photography via Deep Learning. So these researchers used retinal fundus photography, so just taking a picture of someone's retina and using artificial intelligence are able to predict not your risk of going blind, but your risk of cardiovascular heart disease. Remember, the diabetes and microvascular disease, if you have it in your retina, you have it everywhere in your body where you have small blood vessels. So you have small blood vessels in your heart, you have small blood vessels in your brain, you have small blood vessels in your peripheral limbs. So it's not unreasonable to understand that if you have diseases in your retina, that same disease is going on in your heart. And these researchers are using this in a very interesting way. A couple take-home slides from today's discussion is that diabetes is a global issue that is only increasing. We know that early identification and strict blood sugar control can slow the progression of diabetic eye disease. There are direct and indirect costs of diabetic-related vision loss, and that employing a diabetic patient will cost $6,320 per year more in healthcare just for treating that diabetic eye disease than employing a non-diabetic patient. Really want to thank everyone for their kind attention. And Richard, if you have any questions, I'd be happy to.
I do. I know for our audience, our members, there is a service you even provide. You can look at in advance. There's these cameras, right? You talked about that really relatively inexpensive that they can have on site as part of their wellness. You can have pictures taken of your eyes, and then Dr. Lazar can review it in a very short time to determine if there's an issue or not for employees. Is that right?
That's correct. So the camera I have in my office is obviously very expensive, but they have very different versions of that camera, ranging from 5,000 to my version, which is 100,000, which instantaneously takes photos of people's retinas. That image can be emailed to anyone across the globe, and I get emails all the time that I interpret, and I write back to the healthcare provider, and I say this patient has a moderate or mild risk of evidence of diabetic eye disease, and you really need to treat this patient, or this patient can be monitored with strict blood sugar control. So yeah, that is a service that I provide, and I actually have recently partnered with the camera company Nikon that I have, and I'm working with them across the country to interpret retinal photos. So it looks like, unfortunately, in the next 20 or 30 years, artificial intelligence might put me out of a job. But for right now, it's a fun and interesting way to be involved.
Great. Thank you. Lynn, did you want to say something?
I just want to thank you both so very much for bringing this important information to our audience. And really, Dr. Lazar, thank you for all the work that you do to bring a healthy vision and healthy lifestyle to so many people across the globe. It's really important. And just also want to thank all our viewers out there. If you have comments on today's program or suggestions for future guests or topics, please share your thoughts in the YouTube comments that are below the screen. And don't forget to subscribe to the American Benefits Council YouTube channel. This has been the Conversations with the Council. I'm Lynn Dudley, and we look forward to seeing you next time.